related to lipid metabolism. So this is the first case. Please read the case 1. Here it is written as the teenage girl was brought to hospital with the complaint of tiredness and muscle pain. Okay. So on examination, the neurologist found the muscle weakness in girl's arm and legs. Okay. So the chief complaint is tiredness, muscle pain, and weakness. And there is no obvious sign or any specific sign and symptom. So when no obvious diagnosis could be met, the doctor advised for the biopsy of the muscles. Okay. And in biochemistry parameter, when biochemical analysis was done, elevated amount of triglyceride esterified with primary long chain fatty acid can be seen in the blood. Okay. So this is the biochemical finding of the patient's blood sample. And in the bone marrow, and in the muscles biopsy, lipid vacuums can be seen in the muscle biopsy. So what can be the probable diagnosis of this case? Okay. Complaint is tired, muscle pain, and weakness. And what are the causes of this symptom? So this case is the this is a case of carnitine deficiency, because most of the symptom here, muscle pain, tired, and weakness, with no other significant sign and symptom, with elevated amount of TZ along with primary long chain fatty acid. Okay, so this elevated amount of primary long chain fatty acid suggests carnitine deficiency. So carnitine is required in beta oxidation of fatty acid, right? So carnitine is required for the transportation of activated long chain fatty acyl CoA molecule across the inner mitochondrial membrane. Okay, because the long chain fatty acyl CoA cannot cannot go inside the mitochondrial membrane for beta oxidation. So carnitine helps in the transportation of long chain fatty acyl CoA molecule. So this is required for the beta oxidation of the fatty acid. Let's just revise the activation part, that is the initial stage of the beta oxidation of the fatty acid. Here the fatty acid is activation part occurs in the cytosol. Activation part occurs in the cytosol, where the fatty acid is converted into fatty acyl CoA with the help of the enzyme acyl CoA synthetase. And this fatty acyl CoA, the acyl group of fatty acyl CoA is transferred from CoA to hydroxyl group of the carnitine to form acyl carnitine. Okay, acyl carnitine, and this is catalyzed by the enzyme carnitine palmitoyl transferase 1, which is present in the outer mitochondrial membrane. So in this way, the fatty acid, long chain of the fatty acid, that is activated long chain fatty acyl CoA is transported in the form of acyl carnitine inside the mitochondrial matrix. And acyl carnitine is transported inside the mitochondrial matrix with the help of the enzyme translocase. Okay, and this acyl carnitine is converted back into carnitine, and fatty acyl CoA is formed. This fatty acyl CoA will undergo beta oxidation, and carnitine will go back to the cytosol for further use. So this carnitine is required for the transportation of long chain fatty acid. So if there is deficiency of this carnitine, if there is any defect in this enzyme, carnitine palmitoyl transferase, translocase enzyme, there will be a disturbance in the beta oxidation of fatty acid. Okay. So the clinical manifestation of this carnitine deficiency will be in the form of the mild muscles cramp to severe weakness of the muscle, and this can even lead to the death of the patient. Muscles, kidney, heart are the tissues which are primarily affected by the carnitine deficiency. Okay, and weakness of the muscle during the prolonged exercise, it's one of the important characteristic feature, because muscles will depend on the fatty acid as the long-term source of energy. Okay, and long chain of fatty acid cannot be utilized due to the absence of the carnitine, and there will be no beta oxidation, and there will be no source of energy. So muscle weakness can be seen during the long exercise. And some of the other features are myopathy and cardiomyopathy, and hypoglycemia can also be seen in the carnitine deficiency. Why hypoglycemia we'll discuss in the next slide. Okay, na? As this carnitine is required for the transport of the long chain fatty acid into the mitochondrial matrix, there will be block in the transport of this fatty acid. Fatty acid oxidation will be impaired. Okay, so there will be no energy production, less energy production, and all the energy which are required by the body will come from glucose oxidation. So there will be a imbalance between the demand and the supply of the energy, and glucose will be used up for glucose oxidation. So in this case of carnitine deficiency, hypoglycemia can be seen. Okay. So once again, I will show you the case. Here the patient came with the complaint of tired and muscle pain along with the weakness. Okay, so this weakness, muscle pain and tiredness are due to decrease in the production of the energy due to blockage of beta oxidation of the fatty acid due to deficiency of carnitine. So causes of the carnitine deficiency can be due to inadequate intake, as carnitine is synthesized in the liver and the kidney from lysine and the methionine. Okay, so if there is decrease in the amino acid intake, there will be deficiency of the carnitine. And also when there is inability to metabolize carnitine due to enzyme deficiency, carnitine is there, but due to the enzyme deficiency of carnitine palmitoyl transferase, the same symptom will occur, because here in this case also the fatty long chain fatty acid will not be able to transport inside the mitochondrial membrane. As carnitine is synthesized in the liver, during the severe liver disorder, there will be decrease in synthesis of carnitine, and when there is excess loss of carnitine due to diarrhea or due to any renal condition, diuresis or hemodialysis. And one of the hereditary cause in which carnitine is leaked from the renal tubule, that is known as primary carnitine deficiency. And in all this condition, you can see the sign and the symptom of the carnitine deficiency. And also when there is increase in the demand of the fatty acid oxidation, that is during the critical illness and during the major surgery of the when there is increased level of the ketosis, there will be decrease in the carnitine. So these are some of the causes of the carnitine deficiency. So diagnosis of the carnitine deficiency, as there is no specific sign and the symptom, sign and symptoms suggestive of carnitine deficiency are weakness, muscle pain, along with low carnitine level in the plasma and the muscles. Okay, when the carnitine level is low in plasma and the muscles, you can diagnose carnitine deficiency. And the normal level of carnitine in plasma is 1 to 2%, means to 1 to 2% of the normal level. Sorry, this, please ignore this one. Okay, and hypoglycemia is one of the common finding, okay, in the carnitine deficiency. So in order to diagnose carnitine deficiency, you can measure the carnitine level in plasma and muscles. Hypoglycemia can be seen, which will be precipitated by fasting and exercise. And you can do muscle biopsy. In muscle biopsy, lipid vacuums can be seen. So these are the diagnostic feature of carnitine deficiency. So how to treat this condition? Oral carnitine can be given in case of carnitine deficiency. Okay, this after giving oral carnitine, cardiomyopathy and the muscles weakness can be corrected. And all the patient with carnitine deficiency must avoid fasting and exercise. And some supplementation with medium chain TZ and essential fatty acid like linoleic and linolenic acid can also given in case of carnitine deficiency. And this patient required high carbohydrate and low fat diet. No, fat to be due to a problem in the beta oxidation of the fatty acid. In this patient, they should avoid the fat diet. So these are the treatment for the carnitine deficiency. Oral carnitine, and the patient must avoid the fasting and exercise, and essential fatty acid can be given, and high carbohydrate diet and low fat diet. Okay, so this is related to carnitine deficiency. So now coming to the case number 2. Please read up this case number 2. So a child, 6-year-old, come with a complaint of hearing loss, progressive hearing loss. Okay. And on history, it was revealed that the child was born normal, but there is progressive loss of the hearing and loss of the smell. And from the past few months, the child was finding it difficult to locate the things at night. That means there is some kind of the neurological problem and a sensory problem here. And on examination, the child had a dysmorphic features and a flat nose with low set ears. Okay, these are on examination. Vital examination made the pulse was irregular and the liver was enlarged. And lab investigation revealed low level of the plasma cholesterol, HDL and LDL. So low level of cholesterol, HDL and LDL. Okay, here the main feature is progressive hearing loss with loss of smell and difficult to locate the things at night with the feature of dysmorphic feature with flat nose and low set ears, enlarged liver, irregular pulse, along with the lab investigation of low level of cholesterol, HDL and LDL. So this is the condition of the Refsum disease. Okay. So all these conditions are the characteristic feature of the Refsum disease. So what is the defect in this disease? So it is a neurocutaneous syndrome, characterized by the accumulation of phytonic acid in plasma and the tissue. The Refsum disease is a neurocutaneous syndrome due to increased accumulation of phytonic acid in plasma and the tissue. And phytonic acid, as you remember, means you have discussed in your theory class that it is for the metabolism of the phytonic acid, alpha oxidation occurs. So in this disease, there is defective in alpha oxidation due to deficiency of the enzyme phytonic acid oxidase. Due to the deficiency of this enzyme phytonic acid oxidase, alpha oxidation will not occur and patients are unable to degrade this phytonic acid and it will accumulate in the brain, blood and other tissues. Okay, phytonic acid will accumulate in brain, blood and other tissues. Okay. As there is increased level of the phytonic acid, this will replace other essential fatty acid like linoleic acid and arachidonic acid. So in this disease condition, there will be decrease in the level of essential fatty acid and essential fatty acid deficiency will take place in this disease. So clinical manifestation of the Refsum disease. It is a very rare disease with just 60 cases till now. Okay, and the symptom evolve very slowly, progressively from childhood to adolescent and to early adulthood. The symptom will progress very slowly. And mainly the symptoms are neurological and the cutaneous symptom will be seen. Okay, and develop gradually, progressively. Night blindness. Night blindness can be seen in this disease condition. Okay. The night blindness is due to the degeneration of the retina, and it is also known as retinitis pigmentosum. Due to the deposition of the phytanic acid, degeneration of the retina, so night blindness can be seen in this condition. And there will be loss of the sense of the smell. Okay, deafness and the cataract can be seen in the Refsum disease. And there will be a sign of the cerebral ataxia. Okay, for means neurological sign can also be seen in this condition. Enough. Like progressive weakness, foot drop, loss of the balance, and cardiac arrhythmia can also be present. And these are some of the dermatological finding: rough and dry scaly skin. Okay, in this condition. And as in the question, in the case, this morphic feature can be seen: flat nose and low set ears. And if the child comes with flat nose, low set ear, along with all this clinical symptom, you can think of this disease. Okay, so these are some of the clinical manifestation of the Refsum disease. So lab diagnosis of this disease can be made by measuring the phytanic acid level in blood. Okay, so there will be elevated level of the phytanic acid. Normal value of the phytanic acid is less than 0.2 milligram per dl, and in case of this disease, the level of the phytanic acid will goes to 10 to 50 milligram per dl. So treatment. Now coming to the treatment. This chlorophyll plant chlorophyll is a source of the phytanic acid. So all the source should be eliminated from the diet. To eliminate all the source of chlorophyll from the diet. Green vegetables and like the major source like green animal fats, including animal milks, which contain phytol, should be avoided. And plasmapheresis can be given. Plasmapheresis can be used for the treatment. Yeah, in drawn from the plasmapheresis, blood is from the patient blood is drawn and it is filtered and reinfused back into the body after removing of the phytanic acid. So in the worst condition, plasmapheresis can use as a treatment. Prognosis of this disease is very poor if it is untreated. Okay. And due to the phytanic acid accumulation, myelination of the nerve fiber will be disturbed, and cardiac conduction system will also be disturbed. Okay, all these conditions will lead to central and peripheral neuropathy with the symptom of impaired vision and cardiac arrhythmia. And all these conditions will lead to the death of the patient. So the prognosis is poor in case of the untreated patient. So the second case is of Refsum disease. So case number 2. Okay. Now coming to the third case. So here in this case, a 42 years old man presented with a chief complaint of claudication intermittent during the exercise. Now, and family history. There is a significant family history. Paternal family history. In paternal family history, there is a presence of cardiovascular diseases in some of the family members. And the maternal family history was insignificant. Okay. And on physical examination, gentilesma can be seen in the eyelid. Gentilesma is the deposition of the cholesterol. Yellow color plaque can be seen in the eyelid. And bilateral tendon gentilesma, that is fat deposition in the skin, can be seen. And the doctor advised for the fasting lipid profile. And in fasting lipid profile, we reveal cholesterol of 440 milligram per dl, HCl 24 milligram per dl, LDL 25 milligram per dl with high LDL by HCl ratio. So what can be the probable diagnosis of this case? So the question now, what is the probable diagnosis? Name the underlying defect in this case, and what could be the reason behind the increased LDL level, and how will you manage this patient? We are going back to the case. Level of the cholesterol is 440 milligram per dl. So you should know the normal level of the cholesterol in the normal person individual. Normal individual may their normal cholesterol level is less than, this would be less than 200 milligram per dl. And HDL level is around 60 milligram per dl. It should not be less than 35 milligram per dl. HDL level should not be less than 35 milligram per dl. And here in this case, LDL level is 250 milligram per dl. And the normal LDL level is 60 to 130 milligram per dl. And total and LDL to HDL ratio is 4. So in this patient, cholesterol is high, very high. It is more than 200 milligram per dl. And HDL level is also low, less than 35 milligram per dl. LDL level is 250 milligram per dl. This is also high. It is more than 130 milligram per dl with high LDL by HDL ratio. So the probable diagnosis of this case is familial hypercholesterolemia. Okay. As there is also family history here, paternal family history, there is significant paternal family history with the presence of cardiovascular disease in the family member. Now there is family history. So this case is familial hypercholesterolemia. So now coming to this condition, familial hypercholesterolemia, it is an autosomal dominant disease, right? It is an autosomal dominant disease, and it occurs due to the mutation in LDL receptor gene. This is found on chromosome number 19. Okay. So in this condition, there is mutation in LDL receptor gene on chromosome number 19. And due to a defective gene, the LDL receptor is not enabled to, means inability to internalize the LDL receptor. Okay. This familial hypercholesterolemia can be caused by three different types of defect. Here, due to the defective gene, LDL receptor is not produced at all, or mutation